Thank you everybody for joining us for our presentation of Alpha2EQ for the management of equine asthma. I'm Katie Davis, and I'm the West Coast Regional Manager for Astaria Global. And also joining us is Carrie Bosine. She's our Director of Business Development. And we're going to jump right into our discussion. I want to thank Dr. Dan Dreyfus for being here with us. Dan's a graduate of UC Davis School of Veterinary Medicine. He completed his residency at the University of Pennsylvania New Bolton Center. And after his residency, he worked in a group practice in Maryland with a focus on thoroughbred racehorses, and also managed his own referral surgical lameness practice. Dan, thanks for being here. And also with us is Dr. Stuart Shoemaker. Stuart received his DVM from Colorado State University and completed a surgical residency at Louisiana State University in Baton Rouge. He taught at the veterinary school at LSU for 5 years before joining the team at Idaho Equine Hospital as a staff surgeon and co-owner. His passion for sports medicine has led him to be involved in many studies and research endeavors, and we're so grateful to have him with us this evening as well. So without further ado, Dan, I will turn the time and screen over to you. We'll get started. Again, for any of those that are just joining us, feel free to type any questions in the chat as we go along. And also you can unmute yourself and pipe in if there's something that we're covering right away that you want to chat about.
Okay, thank you, Katie.
Right. You bet, Dan. All you.
Hopefully you can see my screen and we will get going. So thanks everybody for joining us. And as Katie said, this is very informal. You don't need to hear me blab nonstop for the next 20-25 minutes or so. If you have any questions, feel free to jump in. And especially if they're tough questions, that's why Stuart's here. And with that, we will set off on talking about what we've looked at using autologous alpha-2 macroglobulin for the management of equine asthma and the pilot studies that we've recently completed and what we're looking at for the future. So just to give everybody a background for those that aren't familiar, the active in the from the Alpha2EQ system is alpha-2 macroglobulin. It's actually a really interesting molecule that's been known for quite some time because of its role in the innate immune system. It's been known for the better part of 8 decades or so, but it lived in the realm of the immunologists and the biochemists, and it's only been within about the last 14 or 15 years that people have considered it as a possible therapeutic, and we'll see in a moment why people have considered it as a therapeutic. So as I mentioned, it is part of the innate immune system. It's mainly synthesized by the liver and released into the peripheral circulation. There are smaller amounts made by macrophages, synoviocytes, chondrocytes, and many other cell types. They just don't make a tremendous amount of it compared to the liver. It's a relatively large molecule. It's not humongous, but it's relatively large, and it has a complex structure, which leads to its complex and interesting mechanism of action, which we'll get to in a couple of slides. It has been conserved evolutionarily across all vertebrate species and many invertebrates. And there are significant parallels, as you might imagine, with something from the innate immune system between alpha-2 macroglobulin and complement. So what makes alpha-2 macroglobulin particularly unique is its multimodal mechanism of action. It's the only molecule that we know of that has these 3 attributes that have been demonstrated, and probably more that we don't know about yet. So the first thing that it's best known for is it is a non-specific inhibitor of all 4 classes of proteases. That does include the matrix metalloproteinases, or MMPs, and the A-disintegrin metalloproteinase thrombospondin motif. Big long mouthful, that's why they gave it the acronym ADAMTS. Those are the main enzymes that contain things like collagenases, stromolysin, aggrecanase, that tend to break down the ground substance of multiple different tissue types within the body. The second thing that the molecule's been demonstrated to do is it has specific binding sites for pro-inflammatory cytokines. So there are sites, and we'll show that on the next slide. There are sites where the molecule can bind pro-inflammatory cytokines such as interleukin-1, interleukin-2, interleukin-6, and tumor necrosis factor alpha, or TNF-alpha. And then the third thing is perhaps the most interesting, and it leads to a lot of future studies that we're looking into is that in a model of post-traumatic osteoarthritis, the molecule's been demonstrated when supplemented to those joints that have experienced trauma to upregulate anabolic genes and downregulate catabolic genes of chondrocytes. That's the only tissue type that it's been looked at for gene regulation up to this point. So in those chondrocytes, it increases production of things like type 2 collagen and aggrecan and downregulates, decreases production of multiple different matrix metalloproteinases and some other factors. So this aspect is particularly interesting because it demonstrates that the molecule truly has a cellular effect on those cell types that it can affect. The result of this three-pronged mechanism of action is that the molecule is far more than just a protease inhibitor, and it actually acts as an anti-inflammatory. It is a naturally occurring non-corticosteroid anti-inflammatory molecule. The way that it does it, not to spend too much time on the basic science part, but it is basically a molecular version of a Venus flytrap plant. So when in its native conformation, here on the left, it's laid out with its arms extended. And when it is in this conformation, it offers up a string of amino acids that's literally called the bait region. When the protease comes along, these little green Pac-Man looking dudes, when a protease comes along and does what a protease does, cleaves an amino acid segment, the molecule undergoes a physical conformational change that has at least three really important implications for its job, for its function. The first is that it traps the protease molecule within these arms, and it literally was dubbed the trapping mechanism by the biochemists that worked this out 51 years ago. The second thing that happens is when in this conformation, those binding sites for the pro-inflammatory cytokines that normally live down underneath the arm here are better exposed. They've folded up or turned up. So the binding affinity for pro-inflammatory cytokines goes up statistically significantly when in this conformation. And then the third thing that happens after it has bound protease enzymes and pro-inflammatory cytokines, then and only then, there's a binding site that is exposed, recognized by macrophages that can bind to it, phagocytize the entire complex, and actually remove it from the site of inflammation. So the molecule doesn't just block the effects of proteases or cytokines, it actually is capable of physically removing them from the site of inflammation, which is an important distinction from a lot of the other active proteins that are present in orthobiologics. There has not been a lot of information or research done to this point looking at the role of alpha-2 macroglobulin in the respiratory tract. We hope to change that to some degree. There was a paper that was published about a year ago that identified a long non-coding RNA that is identified as being capable of inhibiting inflammation and programmed cell death secondary to exposure to lipopolysaccharide in human bronchial epithelial cells. And they then looked at this long non-coding RNA and alpha-2 macroglobulin in humans with the bronchial epithelial cells of humans with COPD. And I know human COPD and equine asthma are not identical, but they certainly are more similar than they are dissimilar. And they looked at this and demonstrated that in these COPD bronchial epithelial cells, both the long non-coding RNA and alpha-2 macroglobulin are downregulated. They also noticed that the exposure of bronchial epithelial cells to the long non-coding RNA positively upregulated the production of alpha-2 macroglobulin, identified the route by which it is done, and they noticed if you knock down alpha-2 macroglobulin, it prevents the inhibitory protective effects of the long non-coding RNA when it protecting against the inflammation and programmed cell death induced by lipopolysaccharide. So it led the investigators to conclude that the results confirmed that this long non-coding RNA can inhibit this LPS-induced inflammation and the programmed cell death, and it does so by promoting alpha-2 macroglobulin expression, which is really pretty interesting when looking at this aspect of respiratory disease. Now, I don't want to spend a tremendous amount of time, and the purpose of this is not to educate everybody on equine asthma, because frankly, a lot of you could probably tell me a lot more about it than I can tell you. But this is just meant as a reminder that environmental dust plays a huge role in the induction of equine asthma, but it's multifactorial. There's a potential role for infectious agents. Within the last several years, a consensus statement from the American College of Veterinary Internal Medicine has divided equine asthma into two large classes. One is the mild to moderate equine asthma or inflammatory airway disease, and the second is the severe equine asthma or recurrent airway obstruction, also called summer pasture related airway obstruction. The clinical signs you're all familiar with: coughing, increased respiratory effort, poor performance, exercise intolerance. Poor performance is actually one of the real hallmarks that is being recognized more and more as the practice of sports medicine is expanding. And certainly nasal discharge can be part of the clinical signs as well. The diagnosis, it can be diagnosed simply on clinical signs and response to appropriate treatment and appropriate changes in management. You can also involve things such as endoscopy, looking for tracheobronchial mucus. BAL, bronchoalveolar lavage, is done quite frequently. It can give you a baseline of the type and proportion of inflammatory cells present in that fluid, whether it's increased neutrophils and eosinophils or the mast cell type of equine asthma. And you can even do pulmonary function testing that will typically demonstrate some degree of pulmonary dysfunction, especially in the more severely affected horses with RAO. The prevalence is surprisingly high. There was a paper published just a couple of years ago that estimates that the mild to moderate form or inflammatory airway disease may be as high as 68 to 80% of the equine population, and this was based on bronchoalveolar lavage. This wasn't strictly clinical science, so they had BAL evidence to substantiate this finding. And the incidence of RAO estimates are as high as 14 to 17%. So we're not talking about a syndrome that affects a small percentage of horses at all. What causes it? It's not completely understood. What is understood is it involves some degree of dysregulation of inflammatory cell homeostasis within the airway lumen of these horses. They've been able to demonstrate increased expression of some of these pro-inflammatory cytokines, such as interleukin-1 beta, TNF alpha, even interferon gamma. And they've noted increased concentrations of some of these same cytokines in bronchoalveolar lavage fluid. Genetics play a role in it. It's not the entirety of it, but it certainly leads to a predisposition, and there are particular lines within particular breeds that have been noted to have higher than expected incidence of equine asthma. And there was a study, again, relatively recently performed study looking at risk factors for equine asthma in the United States and Canadian horse populations. And the one thing that they found that was statistically significant as a risk factor was obesity. Horses with a body condition score of 7 or greater were at higher risk of developing equine asthma than those horses with lower body condition scores. So as we're becoming increasingly good at feeding our horses, we, in a sense, are killing them with kindness because we're putting them at risk for things besides metabolic diseases, but for equine asthma as well. Typical treatment to this date focuses mainly on decreasing lung inflammation. First and foremost, management changes can have a profound beneficial effect in a lot of these horses, but that's not the sole answer for a lot of these horses. Traditionally, corticosteroids, whether systemic or inhaled, have been the bedrock of treatment for equine asthma, along with bronchodilators, mast cell stabilizers such as chromal sodium, and even some of the interferons such as interferon alpha have been attempted. All of these are used in an attempt to quiet the clinical signs that are associated with equine asthma. There is nothing that is currently available that is going to treat and cure equine asthma. And we're not proposing that Alpha2EQ is that cure either. But based on its ability to act as an anti-inflammatory, a couple of years back, through another series of circumstances, we decided to take a look at what happens to horses with equine asthma if you nebulize them with the Alpha2EQ product containing alpha-2 macroglobulin. So we found a group of horses, a small group of horses that had mild asthma. They were not severely affected. They were quite mild. They were all diagnosed based on both clinical signs and bronchoalveolar lavage. We designed a protocol for treating these horses. It was to use 3 mLs of the Alpha2EQ product, diluted to 6 mLs with sterile saline, and nebulize them every other day for 6 treatments. We used a weighted clinical score as the objective outcome measure. The reason that we used it was twofold. One, the same weighted clinical score had been used by a pharmaceutical company that achieved and received approval for a drug that is on the market now for treating equine asthma. So we realized with that it was a relatively validated means of looking at these horses. And it also gave us a way to look at how these horses are doing clinically, because looking strictly at BALs doesn't always give you the clinical picture. In other words, you can have a horse that's improved based on your treatment and is doing better clinically, but its bronchoalveolar lavage, the findings may be identical pre and post treatment. So we wanted to look to see clinically if these horses were doing better. And the main purpose of this initial study was to make sure that the horses could tolerate it. We didn't want them to have paroxysmal coughing episodes if you nebulized them with Alpha2EQ, if they develop nosebleeds, if they, for we were thinking it was going to happen because it's autologous, but we didn't want them falling down and going boom. We didn't want any adverse events associated with it. So when we looked at it, as far as safety goes, there were no adverse events. It was very well tolerated. It actually is quite easy to do, and owner compliance was great. When we looked at an initial weighted clinical score and then did one 7 days following the 6 nebulization protocol, we found that 7 of the 8 horses actually improved. And this is a bar graph representing those 8 horses, the initial 8 horses that we looked at mainly for safety. Again, these are low weighted clinical scores. In fact, they're all so low that they wouldn't qualify for the later pilot study that we did that I'll get to in just a moment. But we were pleased. 7 of the 8 improved. So based on that, we decided to do a larger open label, single arm, non-randomized, non-controlled pilot proof of concept field study to look at the effects of alpha-2 macroglobulin for managing equine asthma in client-owned horses. To be included, they had to be diagnosed based off of clinical signs and or BAL with either IAD or RAO. They had to have been observed to have at least one clinical sign for 14 days or more prior to enrollment in the study. They had to have a history of at least 2 prior episodes of labored breathing at rest, and they had to have demonstrated improvement with an appropriate treatment for equine asthma in the past. The protocol, again, was the same as the one that we used for our initial safety protocol. They had to be diagnosed and they had to have a pre-treatment weighted clinical score. Again, it's the clinical score is based on 9 respiratory related clinical signs. I'll show a overly busy slide next to show you what they are. And it's like a golf score. There's the 9 clinical signs. They're each assigned a numeric grade based on their severity. A big number is bad, a low number is good. To qualify, they all had to have a score greater than 7. They were then, they went through the treatment protocol, same as before, 3 mLs of Alpha2EQ diluted to 6 with saline, nebulized every other day for 6 treatments. Ideally, they had to be off of all other medications for 7 days prior to treatment. However, There were horses that could not tolerate being off of other medications. They still had a weighted clinical score well above 7. They were allowed to be maintained on those medications with no changes in those medications, certainly no increases in doses and no new medication additions during the time on study, and no management changes were allowed. So if they lived outside, they had to stay outside. If they lived indoors, they had to stay indoors. They couldn't start soaking or steaming their hay during the course of the study. And again, we took an initial weighted clinical score the day prior to the nebulization, and then the follow-up weighted clinical score was taken 7 days after the 6th of the 6th in the series. This is an overly busy slide, but just to show you that those are the 9 respiratory related clinical signs that contribute to the weighted clinical score. We certainly can get this to you if you have any interest in it. So what were we looking for? Primarily, we wanted to look at safety. Again, we wanted to make sure we weren't doing any of these horses any harm by nebulizing them with Alpha2EQ. And we wanted to see how they were doing clinically based on their clinical score response. To be termed a success in this study, we chose that they had to have 2 things. They had to have a reduction in their weighted clinical score of greater than or equal to 30% from at the day 7 post-treatment compared to their baseline day 0 score. And they had to have a final score less than or equal to 7. So they could decrease 30%, but not get below 7, and that would not be termed a success. They had to have both of those to be qualified as a success. We were able to recruit 54 horses from 8 different sites at different regions around, geographic regions around the United States, everything from the West Coast to the Gulf Coast, the Southeast, the Mid-Atlantic, and the Northern Plains as examples of where we were able to recruit horses. All the horses that we had safety data for were examined, and there were no serious adverse events reported. There were no changes in temperature, pulse, or no significant changes in temperature, pulse, and respiration within the first hour post nebulization. No horses developed epistaxis or bloody nose following nebulization. There was one horse that developed a transient increase in coughing following nebulization, but frankly, that can happen if you nebulize them with saline, and that the investigator felt that it was transient and was just related to the fact that they were being nebulized. So if we look at a sample of some of the weighted clinical scores, I'm not going to show you all of them. That would put everybody to sleep if I haven't done so already, but these are pretty typical. This is actually the first 5 horses that came in. These horses, you can see some of them started out fairly high, a weighted clinical score of 16. That's a fairly severe case of equine asthma. And by essentially 2.5 to 3 weeks later, 7 days post treatment protocol, the horse was down to a 6. So that literally meant that this horse was incapable of doing anything. It stood at the fence line with copious mucopurulent nasal discharge, gasping for air, and literally went to the point where they could actually tack walk this horse after the treatment. And it had been on multiple different treatment protocols. So all 5 of these horses would meet the criteria to be called a success. This is another group of 5. This horse is not a success. It did decrease, but it did not reach that final threshold of 7 or lower. So this was a failure. This horse was not a success. So if we look at all of the horses that we were able to get all of the data on, and typical of a clinical study, you always have dropouts for protocol deviations. There were several horses that the follow-up weighted clinical score was not performed within the right time period. There was a group of horses that changed from one barn to another. All of those things disqualified them for looking at the efficacy, the weighted clinical score. Of the 54 horses, we did have 34 that reported all the data we were able to look at. And of those 34, we were quite surprised and quite pleased to see that 30 of the 34, or 88.2%, met both of the 2 objective outcome measures to be termed successes. All 34 actually did have a lower post-treatment weighted clinical score than their baseline, and 32 of the 34 improved at least 30%, but they did not drop to that 7 or below level, so they were not termed as successes. There was the one horse that experienced the transient increase in coughing, and again, no significant change in TPR, and no horses developed nosebleeds. So to date, the duration of response to this treatment protocol has varied quite a bit, as you can well imagine, because horses are affected to different levels with equine asthma. It varies anywhere between about a month to several horses who are well beyond 6 months, and they have not been retreated with alpha-2EQ. The more typical pattern, especially for horses that have higher initial weighted clinical scores, has been they are maintained on a single dose, not an entire treatment protocol again, but a single dose about every month. Some slightly more, a couple slightly less. And there have been a handful of horses, small handful of horses, that have specific clinical signs that have been treated since the protocol with additional medications specifically for that clinical sign that they manifest. Interestingly, despite the fact that it was not required for the study, there were a number of horses in our study and a number of horses that weren't in the study but who have been through the protocol who have had follow-up BALs performed at about a week following the initial treatment series. And while it's not all of them, a significant portion of them actually have significant improvement in their BAL profile. So they may start and be included because they've got quite a significant neutrophilic, eosinophilic, inflammatory profile on their BAL. 2.5, 3 weeks later, when that BAL is repeated, it's read out as normal. Pretty interesting. I think that's an indicator in some of these horses of the cellular effects that alpha-2 macroglobulin is capable of due to its gene regulatory abilities. And that's something that we're going to look at. So what are the limitations of the study? Oh, I can pick this study apart like crazy, in large part because I was principal in designing it, so I can always find fault with the things that I've done. It's not blinded, it's not controlled, it's not a huge number of horses, it's not enough to analyze statistically, but it's a preliminary study. It's a proof of concept. And what it's enabled us to do is have enough positive feedback that we have launched into a larger study that I'll get to in a moment. We get asked all the time, as you can well imagine, what about for horses with exercise-induced pulmonary hemorrhage? What about bleeders? We don't currently have numbers. All that we have right now is anecdotal. It's mainly from barrel horses, although there are horses in several other athletic disciplines that we have anecdotal evidence from. And a lot of it has been increasingly surprisingly positive feedback from especially a lot of the barrel racers and again some other disciplines. Many reports of improvement post treatment protocol. A lot of people are following the protocol and then using a single dose as a pre competition dose anywhere between 3 and 48 hours prior to an event, depending on rules and regulations regarding administration times. So where do we go from here? Well, we are just about to complete, in collaboration with one of the United States veterinary schools, we're about to complete a blinded controlled study in horses with equine asthma. Along with the weighted clinical scores, we're in that group of horses, we're also looking at some cytokine and cellular responses in bronchoalveolar lavage fluid. And we also have plans to look at cultured equine bronchial epithelial cells and look at the potential for alpha-2, alpha-2 macroglobulin to have the same type of gene regulatory effects that have been demonstrated in chondrocytes and that we're actually looking at in a couple of other orthopedic type cells, including synoviocytes and tenocytes. If you have questions at a later date, or if you don't feel like asking in front of the group, please feel free to reach out to any of these email addresses, and we'll do our best to answer questions you might have. Thanks, everybody.